Welcome, 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 welcome. Hello, everybody. Welcome to the Clinical Evaluation Center at the West Virginia School of Osteopathic Medicine. We are thrilled to bring to you today our first ever and hopefully annual faculty simulation war. Woo! Yeah! Yes. So thank you all for coming. Thank you to our Facebook Live viewers out there. I'm Dr. Elizabeth Zeiner, and I'll be your moderator over the next hour, during which you guys will get to watch two faculty teams take care of a simulated patient in a simulated environment. This can be a very nerve-wracking experience, let me tell you what. To get up in front of an audience and do what they're going to do, and to get up in front of Facebook Live can be quite nerve-wracking. We have prepared a scenario for them that forces them to work together as a team and that forces them to communicate. And that's what we'll be judging the teams on today, is their teamwork and communication. At the end of their scenario, which will last about 10 minutes, I will perform a short debrief, and then we'll turn to our judges, whom I'll introduce to you in a few moments, and they'll give the team some other critical feedback about their performance. Then we'll have the second team come in and perform as well, and then we'll have our judges judge the teams and see who performed the best. So thank you. Within the case, we have what's called a confederate. A confederate is a person who has knowledge about the case, to which team members will ask, what does this patient look like? Can I get this lab? Yes. What is the result of that lab? That person moves the case along. Our confederate today is Miss Angie, and she's dressed up back there waving to you all. Yes, give her a big round of applause. Show her some love. Yes. And she will also function as the nurse for the team. Now, as you can imagine, because it is pretty nerve-wracking to get up here, we want to make sure that our team members are safe, that they feel safe up here to make mistakes if they make a mistake, that we're not going to yell and boo at them. I've done an extensive pre-briefing with them, and when they come in, I want you guys to clap loud and be proud, okay? Show them lots of love, okay? Very good. I like it. Before we progress any further, I'd like to send a few thank yous out there. First, to Media Services. They have provided multiple camera angles for this event to really immerse you within the simulation itself. Marketing for helping to promote the event for us. Thank you so much. Our faculty and students that are participating in the event. And last but not least, our clinical evaluation staff who have worked tirelessly to set all of this up for you. And by the way, they forced me, yes, forced me, to dress up as Princess Leia. So thank you, CEC staff. I really appreciate that. Yeah, okay. So let me give you some information about what the teams are up against. If I can direct your attention to the monitors, we'll roll the scroll and you can read and see a little bit of history about the case. All right, so it was a little small to read. So basically what happened is Princess Leia and Han Solo on the moon of Endor were being chased. They were captured by the Imperial Army, and they got away because the Ewoks ambushed the Imperial Army. And as they jumped on their speedy bikes and sped out of there, some of the stormtroopers did the same thing and chased Princess Leia, i.e. me, through the forest and crashed into a big tree. Fell about 25 feet, and it's a big disaster. So that's what our team has to fix. Let me introduce you to our judges. First, we have Dr. Earl Bundy, Assistant Dean of Statewide Campus. He has extensive military experience and knows a thing or two about teamwork and communication. As you know, the military pride themselves on teamwork and communication. And sir, thank you for your service. We appreciate that. Next, we have yes, good. Future Dr. Benjamin Kastenbauer. He is a former paramedic in his former life, 4 years of experience, so he also knows a thing or two about communication within a medical team. And he is our current SGA president, so welcome and thank you. And thank you, yes. And last but not least, we have Dr. Craig Boyce, Dean of Academic Affairs, a job in which he would not be successful unless, you guessed it, had adequate skills in teamwork and communication. So thank you, Dr. Boyce, for being here. All right, Risa, let's bring in our teams, yes. As some of you may or may not know, it's Healthcare Simulation Week, and we like to celebrate that. That's one of the reasons that we're doing this here today. Our first team up is going to be the Sim Supers, and they're going to be rolling in here in just a second. Yeah, so the Sim Supers, yep. And so simulation, why do we do that? We do that, the short answer is that we do that to improve patient outcomes. And simulation, medical simulation, has been around actually since about the 18th century, but it didn't really start rolling until the last 2 decades. So in the 18th century, they created birthing prompts to help teach people how to deliver babies, and that was some of the first simulators ever created. They also made statues of people who looked sick, so that people would know what sick people look like, because it wasn't proper, especially for the ladies, to be examined in the nude back then. All right, are we ready for the Sim Supers? Give a big round of applause for the Sim Supers.
Sim Supers, let's go!
They're all gowned up, so you can't see their sweet faces, but we have Dr. Peter Ward, Associate Professor of Biomedical Sciences, Dr. Gail Swarm, Director of the Clinical Evaluation Center, future Dr. Adam Goodcoff,
All right, Adam.
OMS 3 and Anatomy GTA, Dr. Hillary Hamrick, Assistant Professor, Clinical Sciences, and Iman Ben Merzuga, I knew I was going to mess that up a little bit,
Yeah.
Assistant Professor of Biomedical Sciences. So, yes.
All right, let's go, guys.
Welcome.
All right.
Okay, team. As you know, you will have 10 minutes to complete your scenario. Angie will be your confederate and your nurse. If you experience any technical glitches, and you have questions, just ask Angie. We're going to adapt, and we're just going to roll ahead. Okay, do not stop the simulation. If you feel like you are done with your scenario before the timer goes off, please just let me know that. There is a supply table to your right with a bunch of supplies on it. Anything covered with blue towels, you may assume, is all sterile underneath the blue towels. If there's anything here that we don't have that you would like to use, just verbalize it. Verbalize what you need and how you would use that. So let me tell you about your scenario. You are in a well-stocked medical tent on the moon of Endor, where part of the galactic civil war is occurring. Han Solo and Princess Leia were initially captured by the Imperial Army, but were able to escape when the Ewoks ambushed the army. A stormtrooper on a speedy bike was chasing Princess Leia through the forest when he crashed into a tree. The stormtrooper medics found him. And so the stormtrooper medics relay the following information to you. Your patient was found barely responsive. He has a GCS of 8. It looks like he crashed into a tree while chasing Princess Leia. He was traveling at an unknown speed. We estimated the height of his fall by looking at the damage to the tree. We think he fell about 25 feet. There were several broken branches. The bike was on top of his left leg. It took us a few minutes to get the bike off of him. It was really heavy. His last vitals were, AccuCheck, last vitals will be displayed on the screen for you. I apologize.
Okay.
But his AccuCheck was 118. We placed one 16-gauge IV in his right AC, and we held pressure to his leg wound, but it's still bleeding a lot. We put him on a backboard and got him here within 5 minutes. We have no other history on this person. We took his helmet off and put it on the table over there in case you wanted to look at it. All right, you may begin your scenario now.
All right, guys, what do you guys, who wants to be airway?
We'll take your airway up
Okay.
here.
Okay.
Up to the airway.
Okay, sounds good.
All right.
I'll be team leader. Let's go. All right, Angie, can we go ahead and get the patient on the monitor, please?
Hey, buddy,
And
you
get a second
okay?
IV.
All right.
Angie, when you put that IV in, let's go ahead and send labs as well. We'll just do a trauma panel and a type and cross, please.
All right, I've got decreased breath sounds on the right side.
Okay. All right, we look like we're losing quite a bit of blood here. Angie, we're going to go ahead and initiate the massive transfusion protocol as
go ahead
well.
and get 'em out of this.
Let's order 3 units of FFP and 3 units of trauma blood. So you said diminished
So
breath
ordered.
sounds there, Adam?
On the right side, yep.
Okay.
Peter, when you get a chance, if you can hold C-spine,
Yeah, let's take a look at that. You need me to hold this leg for you,
then take a
Gail?
look under the collar here.
Okay.
I wanted to get it a little bit more cut off.
Okay.
All right. Noticing some
Can you hold
tracheal
out
deviation in
Uh-huh.
here.
A little bit?
Okay, so tracheal deviation and diminished breath sounds.
That's correct.
Do we have a patient on the monitor yet?
Good to go.
Monitor's
Thank you.
coming.
Okay,
Let's go ahead and start bagging him.
so we need to think about tension pneumo, guys.
Get this up to O2.
Patient on the monitor.
I agree, Hillary.
So Peter, would you be okay to go ahead and take a look at that chest?
Take
We've
over
got
there,
diminished breath sounds and a tension pneumo, sounds like.
Let's go ahead and put an
Tell me
oral
if you want
airway in
me
this
to pick
patient.
the leg up.
Hillary, an oral airway in this patient?
That'd be great.
Okay.
Monitor's up, doctor.
Thank you. All right, heart rate of 134, guys, stats 89.
Palpating center.
Oral airways
center
in.
If you can
intercostal
hold me
space.
with the
Okay.
left leg.
All right, we're hypotensive as well, so let's see if this needle decompression can help us. Have we gotten a GCS yet,
Let's
just
go
to
ahead and
reconfirm?
reassess the GCS.
Okay.
Hey, buddy. All right.
Okay, airway, we got air coming out of
Checking
the
for
femoral
pain.
cavity.
Great.
You know what's decompressing.
Good.
Still looks like his GCS is 8.
Okay, so let's get set up for intubation with that GCS of 8. And Dr. Ward, are you getting ready to set up for a chest tube there?
You got it.
Great,
Setting up for intubation now.
Okay, the wound is packed.
great,
I got posterior tibial pulse.
perfect.
And Angie, I'm gonna need somebody, maybe you, to help tie me up over here.
Absolutely.
I can get it for you.
C bagging all right? Good.
Okay,
IV is in place, lab sent.
go ahead and pull the white, yep. Great. Okay. All right. All right, so we got labs off. Vitals are the same. Getting ready for our chest tube. We've got our wound packed.
All right. Suit's off.
Good.
All right.
In the meantime, I could probably do a fast exam now.
Sure, it'd be great.
While we're waiting here. Our oral will start. Just gonna squeeze behind your ear, Mom.
Pleurovac is set up.
Great.
All right, Angie, what do I see in the Morrison's pouch here?
You see no lung field rubbing,
Okay.
no free fluid.
All right.
Okay, cleaning the
Grab
chest
some
wall,
fluid.
sterilizing.
You see no free fluid in the abdomen.
Excellent. Bladder view looks clear also.
Okay.
And check the other side here.
No free fluid?
Excellent. Fast is negative for now.
Good. So the only positive finding we have is this tension
The
pneumatic.
decrease,
Okay.
yep,
All right.
inside in there. Get that on the glove here. Perfect. You're right.
Okay, making an incision into the chest. Through. And if come loose, could somebody please retie? And I need a chest tube. Is it on the table over there?
That's right in front of you there.
Ah, right there.
Perfect. Hillary, while we're putting this in, is there
Okay, so
anything
get
else?
the chest tube up to,
Let's go ahead and get the chest tube hooked up.
Perfect.
And then, good. So I think
Good.
we're good for, go ahead and
Go ahead and
intubate.
intubate now.
Yep.
Thank you. And if you grab C-spine, thank you. We've got C-spine covered. We'll drop the collar. All right, here we go. Ready?
Good.
Tube, please.
Can you give me the CO2 indicator, please?
Good. Perfect.
okay,
You have
secure
a-
chest tube in place.
Perfect.
Pop
Do you
that
have a
on for me.
vent over there too, Angie? After we
Yes,
get
I
this
do.
tube in?
And go ahead
We
and
check
bang.
placement?
If we could
Good.
have someone, Angie, once you get the vent over, if you take a listen in the stomach for me, let me know if you hear anything.
Absolutely.
It's yellow.
Perfect.
Awesome, that's a good sign.
No
And we'll-
epigastric sounds?
Perfect. We'll hold off for listening to the lungs until we're done with the sterile field here. Yep, we'll re-put the C-sign on here.
Good.
Yep.
You can slip up under there, Angie, if you want. Go ahead now and just slip up under there. Good.
Lung sounds equal bilaterally?
Good.
Excellent.
Perfect.
To the
All right, so we've got
lungs,
airway,
get this secured.
breathing. Do we have a new blood pressure? All right, good. Looks like our blood pressure's coming up, so that's C. Disability, we scored our GCS of 8. So as soon as we get this chest tube dressed, we'll move on to E, exposure.
Transfer over.
Good.
Get our vent hooked up over here.
You want me to help you go ahead and dress this, Dr. Ward?
Okay, sorry.
Blood pressure is 98 over 58 now. Good. I've got your tape ready. You can just pull those blue towels if you don't mind, and I'll tape it for you.
They're right at the right tip.
Perfect.
And tape it up.
Can you move the arm back so you can?
Another piece there. One more piece of tape. Yeah. Good. All right.
All right, Hillary, we have the tube secured and the patient on the
Perfect.
vent.
Okay, so we've done A, B, C, D. Let's go ahead and E, exposure. Roll the patient and take a look at him, okay? I'll pull the backboard once we roll him.
Break the sterile at this point.
Yep. We'll put
Yep.
that on right now. We'll switch with you here.
All right, so we're going to go this way, right? We don't want to roll on this leg.
Towards the
Towards,
towards
yep.
us.
Amon, you count it.
On the count of 3, 1, 2, 3.
Good.
Okay, I'm checking for any step-offs.
No step-offs noted?
Do we have radiology plates? Oh, right here.
Nothing's noted. Okay, I need lube.
Okay.
I'm going to go ahead and slide these plates under.
Rectal tone is good.
Good. No deformities, good rectal tone, prostate's okay. Perfect. All right, go ahead and
All
roll
right,
back.
1.
We're ready for radiology techs to come on into the room and get our plain films.
Perfect.
All right, I'm going to go ahead and order some antibiotics. I'm going to do vancomycin and Flagyl. And then, since we don't know his immunization status, guys, I think we should do
No
tetanus
blankets.
toxoid and tetanus vaccine.
We'll get some warm blankets down here for him also.
Perfect. And then Angie, whenever you get a chance, if we could get a Foley catheter in and an OG, let's avoid an NG since this is a trauma patient, okay? Otherwise, let's get the trauma center on the phone and get this guy transferred.
Would you like to check the helmet, doctor?
Let's take a look at this helmet so we know if we can report that to the center.
Pretty banged up.
Perfect. Good.
Cross match.
Okay, perfect.
Got some Ewok air in there.
Good. We'll just waiting on our blood from the blood center. Perfect. Great.
Okay, team, Sim Supers. Let's give them a big round of applause. What do you think?
Good job, team.
And you guys can go ahead and take your masks off so we can see your faces. Yeah, all right, good.
Thank goodness.
Booties before track anymore.
And then when you're ready, just join me up here. I think you did a terrific job. Another round of applause, I think, is in order. I think so. Yes, good job. So come close. Oh, here we go. We got us all in. Okay. How did you all decide your roles as a team?
We just thought about what we had, who was most experienced in those areas, and that's pretty much how we came up with who should do what.
Okay, good.
Adam's an ER fiend, so he wanted to take the respiratory stuff, and I know some of the chest anatomy, so they stuck me with sticking the chest tube in.
I got you. That's a good approach. Another approach during simulation would be that if someone wanted extra practice for a procedure, if they were inexperienced and they wanted to learn during the simulation, that might be another way to assign roles. But they went with the most experienced person doing what they know best, and I think that's a good plan. How do you feel the communication went for your team?
Awesome.
We have an awesome here. What else do we have here?
I think it was good. I think it's tough with all of that stuff going on, but I think we did a good job making sure at least the team leader heard every step of the way that step was performed and at least secured to move on to the next. That's how I felt.
We really try to stick to the team leader, not hopping in too much, and that way there's one person sort of seeing that global picture. So as a team leader, I felt like I was up to date throughout the whole scenario with the guys communicating with me. So.
Outstanding. I agree with you. I think you did a very good job at closed loop communication, and you all identified areas where you needed help, and you asked for help, and people jumped in and did that. Very good. If there were anything that you could do differently about the scenario, would there be something? Was there anything that you think that you forgot to do that maybe...
It's one of our better options. It's one of our better runs.
I think we got to most of what we wanted during that. I think certainly after probably a video review, we could find stuff that would be better. But I think we got the job done and hopefully close to the time limit. So,
All right.
yeah.
Let's hear from our judges. Absolutely. Let's hear from our judges. Yes. Very good. Dr. Bundy, feedback for the group.
I thought you did a really good job.
Yes, you have
Okay.
very loud.
Very loud, okay. Thought you did a good job. I really like the way that you kept your cool. The leader, you really did.
Thank you.
You know, I mean, I've seen excellent ER doctors that sometimes did that and others that just flew to pieces. The team was scattered around. You stayed in a real calm tone of voice. I love the comments that were made by some of you guys on should we do this, should we do that, if you considered, and you listened to them. That shows good teamwork. The only thing I'd like to have seen a little more of, and it's just the soldier in me, whether these guys can hear you, whether they're communicating, every now and again reassure him. And I guess you could call him trooper or super duper or something. But just reassure them. You're in good hands, bud. We got you.
Right. I realize this is really fun to tell you guys what you did wrong. All the times you're telling me what I'm doing wrong. So, let's start with Dr. Bourne. Wait, I didn't hear that, but
How long do we have here?
you don't know who I am. I will start out with, you guys were really good. That was really cool to watch your communication, and you had awesome plan of action. All of you had a sturdy role that you stuck with and didn't jump around. Really good intercommunication. You guys definitely knew what you were doing. I really like the log roll too. I see a lot of people screw that up all the time, and that was very smooth for all of you to instantly nope, drop what we're doing, log roll quick. Okay. The two things that stood out for me, did we say that the bleeding was completely stopped with packaging?
Control.
Yeah, Gail said control.
Okay.
But I don't know if you
Yeah, I saw the packaging, and then I looked up, and then I saw the wrap, and it was like, it looked very, very loose on it. I assumed that it had stopped. You guys seem to have done all the other stuff right, but it just looked a little loose for the pressure dressing part of it. And then for the incision, and then finding the chest tube after you made the incision, that would be the only other thing that, because you said, where's my chest tube? After you cut in, it's like, I want to know where it is beforehand. But other than that, great job, guys.
I too think you did a good job. All right. I think the team members remained in their assigned roles. They utilized closed loop communication. You called out critical information as you were going through. You asked for help when appropriate. Other people offered help when they needed it. I think you prioritized your task well, so I think you did a good overall job.
Thank you.
I also like the way that the leader helped when needed. Wherever it was needed, she jumped right in.
Thank you all so much, and you're welcome to eat your pizza now. All right. All right. Thank you. So we're flipping the scenario here. How are we doing here? We're good to go? We're ready for our next team? Are we ready for our next team? Yes, we are. All right. Let's bring them out. She's gonna go get them. We're gonna take a second. So back to my history of simulation. So 18th century birthing prompt was the first one. Statues created of sick people. That was way back when. And then in the 1960s is when we really started getting rolling here. Dr. Gordon of the University of Miami, he created a simulator that was called Harvey. And the students know Harvey, right? We use that in my Heart Sounds lab. You better remember that anyway. And Harvey has every single murmur known to man. And that allows the students to listen, the learners to listen. And that was one of the first modern simulators that was created. The other simulator that we are very familiar with, a lot of us, is Little Annie that we use during CPR, right? Annie, are you okay? Right? Head tilt, chin lift. That's the model that we use with Annie. That was also created in the 1960s. Where we got a lot of medical simulation inspiration from, however, was the pilots. They used flight simulators starting back from the 1930s, and it was so useful to that profession that we realized how valuable that was in saving lives. And I think we're ready for our haptic heroes. That's what I'm getting the signal for. So let's give a big, show them lots of love. Haptic heroes, the haptic heroes. Woo! All right. Oh, they have signs. You guys have signs. Woo! I love it. All right, haptic heroes, thank you. Little pre-brief here. You will have, as you know, 10 minutes to complete your scenario. Angie will be your confederate and your nurse. If you experience any technical glitches, we adapt and we roll on. Ask Angie what your findings should be or would be had something been working correctly, and she'll be able to answer that question for you. If you feel like you've ended your scenario before the timer goes off, just let me know. Hey, I think we're done with our scenario, okay? Your supply table is right behind you right there. Anything that's covered with blue towels is considered to be sterile, okay? If there is something that you would like to have but you do not see, just verbalize what you want, and we can just say, okay, you've got it. It's like magic. All right, so let me give you your scenario. Here we go. You are, oh, they're hugging. All right, banding together. You are located in a well-stocked medical tent on the moon of Endor, where part of the Galactic Civil War is occurring. Han Solo and Princess Leia were initially captured by the Imperial Army, but were able to escape when the Ewoks ambushed the army. A stormtrooper on a speedy bike was chasing Princess Leia, i.e. me, through the forest when he crashed into a tree, and the stormtrooper medics found him. So the medics give you the following information. Your patient was found barely responsive. He has a GCS of 8. It looks like he crashed into a tree while chasing Princess Leia. He was traveling at an unknown speed. We estimated the height of his fall by looking at the damage to the tree. We think he fell about 25 feet, and there were several branches broken. The bike was on top of his left leg, and it took us several minutes to get the bike off of him. It was really heavy. His last set of vital signs will be displayed on the monitor once you attach the monitor. His AccuCheck was 118. We placed one 16-gauge IV in his right AC, and we held pressure to his leg wound, but it's bleeding a lot. We put him on a backboard and got him here right within 5 minutes. We have no other history on this person. We took his helmet off, and we put it on the table over there for you if you'd like to see it. You have 10 minutes, starting now. Good luck.
So Lauren, please assess the patient's airway. Dr. Bridges, please provide cervical stabilization. Dr. Cochran, please evaluate the chest. And Dr. Newman, please pack the leg.
Packing the leg.
Haptic heroes.
Haptic
All right. All right. And Angie, can we go ahead and please get the patient hooked up with the blood pressure cuff, pulse ox, and EKG?
Buddy, you're here with us. It'll be okay.
All right. How are we doing, guys?
All right. Let's see. Another 10. Good. All right. That's over here.
Whenever we get the patient hooked up, we'll reassess the vitals.
All right.
Dr. Cochran, how does the patient's chest sound?
What do I hear in the chest?
You hear absent breath sounds on the right,
Where's the
good breath sounds on the
waiting for
left.
vitals. All right. Is he breathing on his own?
He is breathing on his own.
All right. I'm gonna just
And then
sternal
let's
rub.
take
Sir? Sir, can you hear me? How does he respond to a sternal rub?
He responds to a sternal rub.
All right. So he is he's a Glasgow coma scale of 8, so we're gonna have to intubate him. But first, we'll put an oropharyngeal airway.
Perfect.
Get
And
him
let's
bagged.
take a look at the neck. When you
you're
guys
ready,
do that.
I'm gonna start.
You got the oropharyngeal. Okay, you want to start bagging him and then. Perfect. All right.
Stabilize so I can look.
Oh yeah, here. I'll stabilize the neck. Okay.
Got it?
Yep, I got it.
And then is the patient hooked up yet?
Patient is hooked up, monitor is coming up.
Now that the monitor's hooked up, can we go ahead and put in another 16-gauge IV?
Absolutely.
And once that's placed, can we get trauma labs?
Absolutely.
What do I see
So-
here at the neck?
At the neck,
Vitals.
you see some tracheal deviation
His
to the
patient's
left.
Pretty tachycardic. He's got low oxygen, and
All
his
right.
blood
Collar's
pressure.
back on him. Let him go.
Where is it?
All right, I'm gonna put the oropharyngeal airway in.
So
Dr.
blood
Bridges,
pressure,
thank
but
you.
it looks like patient's unstable, so let's initiate the massive transfusion
Perfect. All right, you
protocol.
can go ahead and keep
So
talking. I'm gonna
Angie,
get
when you're
intubation
able, can we
stuff set
get
up.
3 units of fresh frozen plasma and 3 units of blood going, please?
Absolutely. IV is in place, labs are sent.
So absent chest sounds on the right, and what was going on with the neck, and tracheal deviation, it sounds like a tension pneumothorax. Let's start with needle decompression and prepare for a chest tube placement.
All right, getting test tube materials ready.
And then how's the leg wound looking, Dr. Newman? Whenever you get done wrapping that, please make sure to assess the pulses.
That's the pulses with the leg wound intact.
All right, let me know if you do. I can stop doing this and switch.
So it looks like the
First unit of blood is infusing.
perfect. Patient's hypotensive. We'll see if the administration of blood helps that.
All right,
So a
so
little
doing okay, Dr.
tachycardic.
Bridges?
What do I feel? Angie, what do I feel?
You feel positive pulses.
Leg wound intact and positive pulses on the left-hand side.
All right, leg wound is packed. Dr. Newman, once you get the suit cut, please do a fast exam, please.
Fast exam after the suit is cut.
Getting ready to do the needle decompression.
Dr. Bridges, you still bagging okay? All right.
Needle decompression started. Do another assessment of vitals here. Looks like patient's still pretty tachycardic, still hypoxic, and still hypotensive. So continue what we're doing.
All right, let me know if you need to switch.
Yes, go ahead and get ready for chest tube placement. Looks like needle decompression is done.
Dr. Cochran, do you need help with the materials? I'm going to have some help.
All right, here, why don't you, I can do bagging if you want to help her. Perfect.
This out of the way.
Sorry.
And I'm behind you, Dr. Cochran, to help with your gown.
Clothes are removed.
Perfect. Clothes are removed.
Bagging okay?
Bagging okay.
Alrighty, is everything ready for intubation when ready?
Come on your side view.
Let me get out of your way, Dr. Newman.
Somebody can help me get the arm up.
Here, I can.
You see no free fluid?
No free fluid.
No free fluid?
No free fluid. Confirm.
No free fluid.
No free fluid on the bladder.
Alright,
Left
looks
upper
like
quadrant, subcostal or free of fluid.
It is free of fluid, but you see no lung rub.
No lug rum. Free of fluid on the right hand side. What do I see?
No free fluid.
No free fluid.
Looks
And
like
on the
your
left hand
gown's
side, what do I see?
No free fluid.
No free fluid.
there we go.
Confirm.
Alright, thank you for performing the
Dr.
fast
Bridges, get the
exam.
arm up.
Arm is going up.
As soon as this chest tube is in, Dr. Bridges, Dr. Newman, we're going to need your help getting over here for the intubation.
So it looks like the oxygen saturation's come up a little bit, but patient's still pretty tachycardic and his blood pressure's
I'm
still
okay for
pretty
now.
low.
If she needs any help with anything.
Need help with anything?
Okay.
Okay.
All right.
So if you need help.
Before we intubate, we're going to have to remove the C-collar. So, Dr. Newman, if you want to bag.
I'll continue to
Dr.
bag.
Bridges, when the time comes, if you can remove the C-collar.
I'm going to move this.
Or if you can hold C-spine, I'm sorry, and I will remove the C-collar.
While you guys are doing that, I'm going to assess the helmet for damage.
All right.
So it looks like it's pretty scuffed up. Do I see any breaks in the helmet?
Where's the
got
intubation
some
stuff?
leads in
Okay,
there.
intubation materials over here and ready to go when we're ready. I already checked the.
Based on the look of the helmet,
the,
patient could have some head trauma, so
balloon
be
to
careful
make sure
with the
it's working
intubation,
properly.
okay?
Dr. Newman, are you going to help us with the collar?
I can help with the collar.
Why don't you walk
Transfer.
around to the other side? I'll take over this
Okay.
so that we can get access to this.
That's a good plan, guys.
And get ready to insert the chest tube, help her with respiration.
All right, here on the other side.
All right, when she's
Not
not
yet,
yet,
we
when
have to
she's.
wait till she's done with the chest tube.
Yep.
And you can reach the materials back there, okay?
Yes, I can.
The Pleurovac is set up?
Everything's set up.
Pleurovac is set up, and everything's set up for the intubation?
Yes, it is set up for the intubation.
Alrighty. Has the C-collar come off yet?
Not yet.
Not
We're
yet.
waiting for the chest tube to be inserted first.
It loves the little thread.
Okay. And then once the chest tube is placed and we get the patient intubated, we'll need to re-listen to the chest to make sure that everything's in place accordingly.
We'll re-listen to the chest once everything's in place.
All right. And blood's going. Blood pressure's still pretty low and he's still pretty tachycardic. No real change in the oxygen saturation at this time. But he's not worsening, so I think we're all right.
When we get ready to take the collar off, what do I do with this?
So give that to Dr. Newman. You hold C-spine. I'll take off
Getting
the
chest
collar
tube
and
hooked
remove
up.
it.
Pleurovac
So then you just
hooked.
focus on holding on
All right.
C-spine.
Up.
Okay, I'm going to unhook here, get this stabilized before we move so I don't pull it out. Can you see the dressing tape?
And then once the chest tube
It's
is
on the
It's
other
on
side
the
of the.
other side.
It's on the other side of the table here, Dr. Cochran.
And then once the chest tube is hooked up, make sure the needle comes out of the chest as well.
All right, Dr. Newman, are you ready to take over bagging?
Take over
I'm
bagging?
ready.
All right. Here, Dr. Bridges, you go in front of me over here. Perfect. All right. All right. Once you have.
So it looks like the blood pressure's gotten a
All
little
right.
better.
Are you ready to
The
remove
heart
the
rate's
C-collar?
coming down.
Yes,
He's at
we are.
109.
All right.
Oxygen is still
Removing
better.
C-collar, holding C-spine.
So we're at 98%. So it looks like that
You
chest
focus
tube
on
has
bagging. I can
helped.
take care of this collar. Here we go. All right. I'm going to move it in between you guys. Okay. Here we
There
go.
we go. The
All
head
right.
stabilized.
Dr. Bridges, you got it? All right. I'm just going to get the intubation material. All right.
Ready?
Yep, ready.
Okay.
Bag removed.
Intubation is happening.
All
You on
right.
your way?
Nope, you are just fine. Just stay down. There we go. All right, and I see the vocal cords. Angie, can you pass me the intubation tube, please? Thank you.
You have positive breath sounds in all lung fields. No epigastric sounds noted.
Perfect. We're going to want to recheck that once the patient's fully intubated.
All right, tube is
But
inserted.
it looks like the
All
chest tube
Do you mind
has
inserting
helped.
this?
I can come around
Thank
here. Perfect. And
And
CO2
attach him
line.
up to the ventilation system.
All right.
All right. Perfect. And then do you mind attaching the tube? Perfect. All right.
And
Thank
how's
you.
the CO2 looking?
We are attaching it right now. We're attaching the CO2 right now.
Okay. We're going to reassess the vitals. So it looks like the heart rate's come down nicely. His heart rate's 97. His oxygen's 98%. And his blood pressure's coming up nicely.
You want us to reattach the C-collar?
Yes, please.
Okay, haptic heroes. Give big round of applause for the haptic heroes.
I know we didn't get to roll.
Please take your masks off and then join me right over here. Good job, guys. We knew you were dying to do that. Yeah. All right. Okay. So, how did this scenario go for you guys?
Faster than expected.
It went faster than expected. Yes.
10 minutes goes much faster.
Yes.
Do everything that we would have wanted to do.
Gotcha.
But I think everything we did, correctly. So I feel pretty confident about that.
How did you assign your roles to the team? How did you decide who did what?
Well, I like to tell people what to do, so clearly team leader made the most sense.
I learned how to intubate in CS2, so I wanted to practice some more.
I don't really know how to do much when it comes to patient care, so I took the job where I could do the least harm.
I always wanted to do a chest tube.
I thought I could pack a leg.
I like it. If there was anything that you all could have done differently during the scenario, what do you think that might be? Do you have anything?
Finish.
Yeah, get further.
Just finish it.
Yeah, absolutely.
All right. I think you guys did an outstanding job at communication. I really liked how you did closed loop communication very well, and I think you did a good job at directing the team as to their roles. One thing that to consider when you had a little bit of downtime, perhaps doing some of that primary survey, feeling around. You are the haptic hero, so we would expect some touchy-feely stuff to happen. But other than that, I think you guys did an outstanding job. Big round of applause. Let's hear from the judges. We'll start with Dr. Bundy.
Yeah, there's one thing I wanted to ask you. This is a trooper. Now, are they like people that just take care of everybody? This guy's supposed to be a bad guy.
He is.
Okay. Well, you took care of him like he was on your side. I guess you're on the good side. You seem to be. But you really, that's excellent. You take care of wounded people no matter what. Wonderful. Outstanding control. Outstanding communication. Gosh, and you were very helpful when you were needed. You were the Energizer Bunny? Is that what you said? You were everywhere, just zing-zanging around. And you also, when you got an order or command to do something, you were right back on it. We did, completed, executed. I like that. So I'll turn it over to the student. He's probably got better.
I was telling the other group, this is fun to tell you guys what you're doing wrong now. Yeah, just be nice to me later. Oh, yeah, constructive criticism, of course. Yeah. Great communication between all of you. I love the you're doing this, and you're doing this, and you're doing this. Right at the beginning, you all knew what you're doing, and yeah, did a great job at it. I'm going to second Dr. Bundy's statement that do you run marathons? Because you went around this patient 5 times. It can be its blessing and its curse that I've found is when there's somebody that does multiple jobs. Usually when you can stick on one thing, it's better. But also, you knew what you're doing with each thing that you're getting to, and you weren't stepping on anybody's feet, really. So that was great. The only thing that I would really bring up is we were looking at the chest tube after you placed it. The placement was great. It didn't look like there was anything holding it on, though. And I know that it is not a very good surface to stick stuff onto, and I think you might have wrapped it right when you put it in, but whatever you used to tape it in place shot off of it, so it was just dangling there.
That's not their fault, though. They have no control over the supplies that we provided. I assume that they taped it and they did a good job with that.
All right. Good job. All right.
So do we have a couple minutes?
Yes, absolutely.
You guys can sit down.
Thank you, Dr. Kira.
No, I'm going to talk to the group. Yeah. Okay. All right. So we need to address the 480 million ton Death Star in the room. Why did each of these patients die of excessive acute radiation syndrome? How come? Why did that happen? So it's obviously retrospectively that somebody missed something in the history. Okay, so we have first-year students here, right? What's the most important part of your history and physical? It's the history. It's 80 to 90% of the diagnosis, right? So in this case, we missed something in the history, and because of that, both our patients died. Okay, so what happened here? So I think we can kind of guess from the history. This trooper was speeding along on his anti-gravity bike, which is powered by an electromagnetic field, which is generated by a thermoelectric engine, which is powered by strontium-90, right? And he crashed into a tree. Well, obviously, the reactor casing must have cracked, and when the bike fell on the trooper, it spilled strontium-90 all over the trooper. Okay? Yeah, Brian knows that. Okay, so what was missed here? I mean, should we have got a full history? Of course not, because we got a full history, the patient would have bled to death by the time we got the history, right? But in the case of trauma, as you should read in your textbook, chapter 27, the last chapter, it talks about emergency situations, life-threatening situations. They go over the primary, secondary surveys. They basically did the primary survey here, and they talk about an ample history, where A is allergies, M is medication, P is past medical history, L is your last meal, and E is the events around the situation. So we have to make sure we get an ample history. Now, luckily, this is a Boba Fett clone stormtrooper. So at the time he was born and removed from his incubator, he was given an alphanumeric designation, which was tattooed on him, and then a chip was inserted. So we know everything that's ever happened to this person. Okay, so we know his allergies, medications, past medical history. Last meal, well, we know what ship he was on, our unit he was on, so we know what ship he was on, so we know when his unit went to the mess hall, and we pretty much know what he ate. Okay, but what we don't know is all the events around the situation, which is what we just learned. He must have crashed into that tree and must have been exposed to the strontium-90. Okay, so what? The text there failed to ask about that or failed to get the basic required radiation levels that he should have obtained at that point. If we had got a baseline radiation level, we would have known he'd been exposed to radiation, and we would have decontaminated him. Students, even the first-year students know that if you're exposed to radiation, you're exposed to chemicals, or you're exposed to biohazards, you need to be decontaminated before you're brought into a med unit. Otherwise, everyone gets exposed to that radiation, right? All right, so why did and that's very important because the needs as you all know, the needs of the many outweigh the needs of the one sometimes. And in this case, that's one of those cases, because you might say, well, he would have died if we had spent the time to decontaminate him. Well, he died because we didn't decontaminate him. Okay? So this is one of those cases where you need to make sure it wouldn't have taken that much time for the tech to don a radiation gear and put pressure on the wounds and gone ahead and used the ambu bag while they were waiting for him to be decontaminated. All right. But that's besides the point. All right. So he came here. Why did he not die sooner? Well, we all know that the gamma radiation is stopped by 18 inches of concrete or an inch of lead. And that's why they use an inch of lead on the containment vessel on the speeder. But his suit also protects him. It mitigates the gamma radiation and it blocks almost all alpha and beta radiation. So he was pretty safe until we removed his suit in the med bay, at which time he was exposed to lethal levels of gamma radiation, as were our two teams, who will be sorely missed. And for all the students in the audience, Dr. Zeiner tells me that she will, either at the end of this semester or early next semester, be sending out an email recruiting students to participate and join the next teams that will be participating in the next Sim War. So pay attention to that. I think we should all give our teams a round of applause. They did an excellent job. They were quite efficient, and we can look at this as this exercise as a win for both of them. But I think we also have to look at it as an example of what not to do. Now, the good news, there is good news here. The good news is that Dr. Zeiner had herself and the judges pre-treated for radiation exposure, just in case something like this should happen. So we're going to be fine. Okay. How many of you had the salad for lunch? Good. The genetically modified greens? Great. You're going to be okay too. Okay. But you know how they spread all this stuff all around the room here? There's strontium-90 everywhere. This is a cesspool of gamma radiation. For the rest of you, if you develop any nausea, vomiting, diarrhea, fever, bleeding from gums or orifices, or just feel really fatigued, you should make sure you come to the med bay and get evaluated for acute radiation syndrome. All right, may the force be with you. And I'm going to turn the mic over to Dr. Zeiner in case she has any last words for our teams or the audience.
That was an outstanding assessment, Dr. Boyce. Thank you. Thank you very much for that. And our judges, I think, have picked a winner. Yes? 1 second. Okay, so flight simulators. Woohoo, back to that. All right. So they really showed us how it was done. And that was too brief. Okay, what do we think? Okay, you all decide. Okay, I'll give the mic to.
All right. Well, I'll stand up for this to see you guys. We want to say that everybody did an amazing job, and it was a pretty hard decision. We are going to go with, though, drum roll, the Haptic Heroes. Congratulations, guys. Your communication skill was amazing.
All right. Come on up and get your trophies, Haptic Heroes. Yay! Woo! Here you are.
Oh, thank you.
You're welcome. Here you are. You're welcome. Yes. Yes. And last but not least, Dr. Cochran. Here we go. All right. Oh, yes. All right, I concur. Both teams did an outstanding job. And thank you all for coming. Thank you, and have a great day. May the force be with you all.